All right, I'm going to go ahead and introduce Dr. Harris Jackson. She's the Chief Operating Officer and part owner of OmegaQuant Analytics. She's also the Assistant Professor in the Department of Internal Medicine at the University of South Dakota Sanford School of Medicine. She received her PhD in Nutritional Sciences from Penn State University in 2013 and completed her training to become a dietitian in 2014. She continues to do research in the area of omega-3s in maternal health, also helping create the prenatal DHA test and the mother's milk DHA test. Dr. Harris Jackson, thank you so much, and I will turn it over to you.
Thanks, Tavis. Let's get to sharing here. Okay, how's that look, Tavis?
Looks good.
All right, thank you. Thank you, everyone, for joining today. This is a good series, the Omega-3 and Brain series, but it turns out there's just so many ways that we study the brain. And today we're going to talk about mood. I also want to just put a disclaimer. I'm a PhD RD in nutrition. I'm not a clinical psychologist or not trained in some of the outcomes in this area, but I'll be presenting the research around it and some clinical guidelines from experts in this area. But if you yourself are an expert and see anything that needs to be corrected, please let us know, educate us. This area is really interesting and also very kind of new for omega-3s, I would say. Outline is essentially what was sent out by Becky talking about omega-3s being beneficial. Mood is what we're calling mood is mostly we're looking at depression, anxiety, and other areas around mental health. Looking at the research for omega-3s and mood health, testing the patients, how do you use it in clinical practice? What kind of dosing are we looking at? How often do you test? So we'll get to all of this. And as always, if you guys have come to multiple of our talks, you've probably seen a lot of these slides before, but we have to introduce omega-3s for anyone that's new here. So omega-3 fatty acids are polyunsaturated fatty acids. Their first double bond is on the third carbon from the omega end of the molecule. Let's see if I can do that. So these are ALA, alpha-linolenic, EPA, and DHA. Eicosapentaenoic and docosahexaenoic acids. These are kind of the main omega-3s you hear about. ALA is the plant-based omega-3 in walnut and chia seeds. That's not what we're going to be talking about today. We're talking about the longer chain EPA and DHA. Those are coming from preformed in fish and fish oil. That's where they're naturally found in the environment. But the body also can make some EPA and DHA from ALA. It makes it this nutrient a little bit complicated. So here's just a really basic overview of how the body converts the shorter chain ALA to EPA and DHA through a variety of steps, adding carbons, taking away hydrogens, creating double bonds, basically just adding more complexity to the structure of these fatty acids. But you can see over here, so this is the internal pathway that can happen in the body. It's very, very inefficient for most people. Genetics can affect how efficient this pathway is. But for the most part, a high dose ALA may raise EPA levels in the membrane, but very likely DHA levels will not be changed. So that's something that we are seeing more and more. So that's why it's really important to get EPA and especially DHA from food and supplements. And uniquely, omega-3s, the DHA, long chain omega-3s, those are really only found naturally in fish and fish oil. Algae in the ocean create these fatty acids, which are eaten by the small fish and the bigger fish, and on it goes. Thankfully, now we can make supplements directly from the algae, what the algae produce, so they can be completely vegan and provide EPA and DHA. You can see up here the other plant-based ALA that is the plant-based omega-3 is talking about ALA. A lot of the research is not on ALA, it's on EPA and DHA. And over here, you can see these are examples of what becomes of EPA and DHA. These are a lot of acronyms that I'm not going to go over all of, but these enzymes take EPA and DHA from the membrane and create all of these metabolites that have effects all over the body and are a big reason why EPA and DHA have found to be so important for health. The omega-3 index is a status marker of EPA and DHA in the body. So it's technically a measure of the amount of EPA and DHA in red blood cell membranes specifically, and it's expressed as a percent of total fatty acids. Here is a nice picture of a red blood cell membrane. It has a phospholipid bilayer, as most cells do, and we have all of these different fatty acids inside the bilayer are different structures. We measure about 24 different kinds of fatty acids, ranging from saturated fats to polyunsaturated and trans fats. We take the total of that over the EPA and DHA that we measure, and we get a percentage. So here, the example, if 4 of these 64 fatty acids are omega-3s, EPA and DHA, the omega-3 index is 6.25%. The red blood cell is unique. Measuring the membrane status of a red blood cell is very indicative of what's happening at the tissue level. So we've shown in more animal studies and some human studies that the higher omega-3 the index is in the red blood cell, the higher the content of heart membranes is, and the higher EPA and DHA content there is in heart, muscle, I believe spleen. The only major organ that doesn't correlate really strongly with the red blood cell is the brain, unfortunately, but the brain is more enriched in EPA and DHA than the rest of the body. And I'll show you in a minute that certain parts of the brain do have higher correlations with red blood cells, but maybe just not the entire brain in general. So the omega-3 index is not only an omega-3 status marker, it was created to be a risk factor for heart disease in particular. This is showing, these are all different studies from that were put together by Harris and Von Schacke in 2004. They were looking at studies that had outcomes related to cardiac death. And they also had the omega-3 status of red blood cells measured in all of these different cohort studies. And what they found is that the people in these studies who had an omega-3 index of around 8% were much less likely to die from a heart attack as compared to people who had an omega-3 index less than 4. So from these studies, they were able to create the omega-3 index and provide a reference range indicating that being over 8% puts you in the desirable range, and being less than 4% is undesirable. 4 to 8% is intermediate. So those are the major cut points for the omega-3 index as it pertains to heart attacks and death from cardiovascular disease. These same 4 and 8% metrics are showing up across literature, including in this mood research that we're going to talk about. And for more context, fish, as I said, is a major source of omega-3s, and we see that across the world, if you look generally at cultures, fish-eating cultures like Japan and South Korea naturally have an omega-3 index of about 8% or higher without any supplementation. And then Spain and Norway have very good status. They have a lot of fish in their diet as well. The US and Canada average out around 5.5% omega-3 index. But we see that those that are very, very low are US vegans, vegan makes sense, military personnel, athletes. As you will see, people with anxiety and depression and ADHD also tend to have very, very low levels, below 4% of the omega-3 index. So let's define what I'm talking about when we say we're talking about omega-3s and mood. Most of the data we'll talk about today is really about depression. We'll do a little bit on postpartum depression, and then anxiety, psychiatric treatment, bipolar disorder, some studies on prisoner behavior and suicide. These will be the general research topics that we will talk about. And when we are talking about depression, just to make sure we're all on the same page, depression is more associated with people experiencing fatigue and loss of interest, guilt, low self-esteem, hopelessness, as well as excessive worry, difficulty thinking, and decision making, as well as social withdrawal. Anxiety is often goes along with depression, but it has a very different presentation, even though it has a lot of these the same aspects are in anxiety and depression. But with anxiety, you're getting a more of the rapid heart rate, kind of the hyperactivity, hypervigilance, panic, and also not able to think very clearly, but kind of a different presentation. So again, today, mostly we'll be talking about depression, and we'll be hitting on all of these other topics as well. So the mechanisms of action are this kind of similar to what we see with a lot of other health aspects. So if we just look at depression, the main pathophysiology is thought to be an imbalance the serotonergic and the noradrenergic transmission pathways, as well as chronic systemic inflammation. So when we're talking about transmission of a signal, that is within a cell, outside of the cell, it's going to receive some kind of chemical, and that's trying to send a signal to the cell to either make a type of protein or shut something down or start the inflammation cascades. When the actual membrane structure here is full of fatty acids, those actual fatty acids that make up the membrane affect how well that signal is transduced. It affects how well these protein membranes function. It also affects the ability of the signal to be passed from the transporter to wherever it needs to go in the cell. All these different G protein mediated signal transduction, membrane bound enzymes, protein kinase C, those are all major ways that the cell sends a signal. And the omega-3 content changing the membrane fluidity and structure of the membrane affects all of these ways the cells communicate. So the signal transmission is one major way we're having a higher omega-3 status in the cell membranes, affects how is affecting depression. And then it's also, we know omega-3s are anti-inflammatory. Primarily the metabolites of the omega-3s, see how they can be pulled out of the membrane. They can be affected and changed by these enzymes, both inside and outside the cell. And those create eicosanoids and specialized pro-resolving mediators, which both are less inflammatory than their omega-6 counterparts, but they're also pro-resolving, meaning they help heal an inflammatory event hours or days after the event has occurred. So having not enough of both of those actions leads to having chronic systemic inflammation because the inflammatory event is never fully healed. So those really are two of the main reasons why we think we're seeing these positive effects with omega-3s and depression. Like I said, brain is not well correlated with red blood cell omega-3 levels, except for we did see serum omega-3 levels in this study, which included the brains of people who lived to be over 100 years old and serum levels because they didn't have red blood cell levels. And they did find a correlation between having higher omega-3s in their serum and higher omega-3s in the frontal lobe and the temporal lobe of the brain. And these are pretty major areas for what we're going to talk about today. And so getting a little bit more specific about the region of the brain and omega-3 status shows that what we do have in our body and going into our body, even as adults, not just during the developmental period, is really can affect the composition of the brain. I also just wanted to note that in this, we will be talking about some studies where we're using plasma or serum or plasma phospholipids as markers of omega-3 status. A lot of studies do not save red blood cells, and so they end up having to measure EPA and DHA in plasma and plasma phospholipids. Here we've correlated those to the red blood cell levels with our own data. And we see for plasma phospholipids, that's a pretty good marker because a phospholipid in plasma is mostly indicating the membranes and not the triglycerides or cholesterol esters. So this is a really good secondary marker. Overall plasma is a little less good, but we can get a pretty good idea of high and low omega-3 status with this. So this is just to say, as we go along, and if a study is talking about plasma or serum, we can still correlate that back to the omega-3 index as well. Let's go into research on depression. So here I have a lot of meta-analyses. They're kind of the easiest way to just get a handle on all of these studies that have been conducted. This one was specific to studies between 2010 and 2020. And what you see down here, you see all of these little lines are the effects of each of these studies. If the little green dot in the line is more to the right, in this case, it means the placebo was more effective for depressive symptoms. If it's more to the left, it means the omega-3 treatment was more effective. And down here, the big diamond shows kind of the overall average effect when they've weighted all of these studies to account for the different sample sizes. And so when the diamond does not cross this line at 0, that means this is a significant effect, and it's in the direction of favoring the omega-3 treatment. So in this compilation of studies looking at depressive symptoms, they did find that there was a significant, modest beneficial effect of omega-3s. And this was published in 2021. Another meta-analysis from 2019. So what we're going to be seeing is meta-analysis are coming out all the time, and they just keep adding one study and then one more study. So it does get really confusing. So it's important to try and get the latest meta-analyses. Here we see almost the exact same thing. This is omega-3s in depression. So they've added a few studies to the last one. Still consistent. You can see that effect size is significant. It's still modest. This included over 2,000 participants from 26 studies, and they did find an overall benefit. Here they were also looking at EPA and having supplements that are either pure EPA or a higher EPA than DHA supplement. And they did find that these were more effective than placebo and more effective than the high or pure DHA supplements, but they only found this to be effective at doses less than a gram a day. And this is a little bit confusing because and the other stuff I'll show is it's looking at 1 to 2 grams a day and needing that to be effective. So as we go along, we will start to see the research is not 100% congruent. And this isn't even all the research. There are plenty of meta-analyses that find no effect. And there are lots of reasons for that. So just take all of this with a grain of salt. A lot of these studies are small. We need better, more highly controlled studies to be able to get better granularity on, is EPA really the most important piece? Is it the dose? Well, most of these studies don't measure baseline status of omega-3 index anyway, and we found out in other areas that's critically important. So we're just starting to get going on this using omega-3s in this field. So the VITAL study was conducted in individuals who were healthy at baseline. This was a primary prevention cardiovascular disease study. And they were giving omega-3 at a gram a day of Leveza, which is EPA and DHA, and they're also giving vitamin D. And they followed these people over 5 years, looking mostly for differences in really just, are people developing any kind of chronic disease? And are they more or less likely to develop that based on if they're in the omega-3 arm or the vitamin D or the placebo or the combined arm. So interestingly, in this one, with over 16,000 subjects and a 5-year follow-up, they found that people on the omega-3 arm actually had a higher risk of having some developing some depressive symptoms. There was no difference in mood scores. And so it's not a total slam dunk. And you can see here, this is the survival curve, the cumulative incidence actually. You can see it's a very close line between the omega-3 arm, which is orange, and the placebo, which is blue, but there's still a significant difference here. One of the main issues with the VITAL study was that, number one, most of these people were healthy to begin with. This is not a depressed cohort with depressed people in it. And the other thing is that in the other outcome studies, we've seen that there's a real issue with baseline status. The baseline status of this group for omega-3 and vitamin D was pretty good, higher than average. So that's another issue. If you're kind of treating a group that doesn't need it, it's hard to understand what these outcomes mean. So that's something to be aware of as we're looking at these studies, but this is still an important study, very well-run study that found something that we wouldn't expect to see. Now let's look at some work that we actually have blood levels on. The other stuff is primarily just supplemental studies, not our favorite when we don't have blood levels to go along with it. So the omega-3 index, and these are some case control studies. So a case control means you're going to have a case, which is somebody who has depression, and a control is a person without depression who is the same age and sex as the case. And then we just kind of compare these groups to get an idea of what's different. This was done in 3 different countries. We have matched not the same numbers of controls and cases. And then we have the omega-3 index for these countries, and this is the p-value for the difference between the omega-3 index in the depressive cases and in the healthy controls. So first you see Korea, the overall average is already over 8%. That's that cultural fish intake effect. You still see that the cases, the people with depression, have a lower omega-3 index than the controls on average. You see the same thing in Germany. Cases are below 4%. The average is 5%. This US cohort is particularly low, but you still, even at this very low level, you still see the cases are on average lower than the controls. The omega-3 index is inversely associated with depressive symptoms in heart cases. This is a study that Dr. Harris was actually involved in Kansas City. They measured the omega-3 index in 759 people. They were in the hospital for acute coronary syndromes, which is mostly having a heart attack. It does include some unstable angina as well. They took patient health questionnaires, and then we used these scores to find potential predictors of depression risk in these people. What they found was being a smoker, having diabetes, or hypertension increased the risk of having depressive symptoms. You can see that here. Having a high omega-3 index, being older, being male, and being Caucasian all indicated a lower risk of depressive symptoms. They found that there was no relation with BMI or not a significant relation with BMI or education and depressive symptoms. But in another extra analyses, they found that for every 1 point improvement in the patient health questionnaire score, there was a 1 point improvement for every 4.5% increase in EPA and DHA. So even taking into consideration all of these outcomes, there was still a significant association between the omega-3 index and lower depression scores. So that's pretty powerful stuff. Here's a little bit of a confusing one. This is the Boston Puerto Rican Health Study. Again, this was looking in a group of people it's more of a cardiovascular disease focus. But it's still a really interesting cohort study. So we measured omega-3 index in 787 people, primarily women, 57 average age. and these are Puerto Ricans in Boston. They measured the omega-3 index and depression symptoms at baseline and after 2 years. And so what we see is a lot going on in this graph. So I'm going to really need to break it down. This, the y-axis is this depression score. The x-axis is the omega-3 index. And you see most people are really around that 4% range. So this is an America, being in America this is the average omega-3 index you'd expect. But then these are 4 different lines. These are based on a marker of oxidative stress. And this is a urine test that is a metabolite of DNA repair. So what they found was only the people who were expressing very high levels of oxidative stress had a significant relation between depression scores and the omega-3 index. So people with very high oxidative stress and also very low omega-3 levels were at the highest risk of having more depressive scores. A little bit convoluted, but it kind of makes sense with the inflammation story as well. We also don't have enough people, a big enough range in omega-3 levels to be able to really see what's going on in the whole group. If we don't have, there's hardly any above 8%. Looking at the omega-3 index just in people with patients with depression and anxiety, we can see there are healthy controls. There are 62 of them. This is omega-3 index, average omega-3 index in people with major depressive disorder, MDD, but without anxiety. And then the final group is people with MMD, not MDD, and anxiety. And you can see that there's a significantly lower average omega-3 index in the group with MMD and anxiety. Let's look at this Japanese cohort, and it's again, like you have to change your mindset around what average levels should be. So we're looking at quartiles of EPA and DHA. The quartile one has the lowest amount of EPA and DHA. Quartile 5, these people have the highest. This is done in Japan, and the quartile 1, the lowest group, had an average omega-3 index of about 8%. So our target range is their lowest range, and their highest range people had omega-3 index of 17%. It's just wild. It's just a completely different scale than what we are used to here. And even at that high scale, we do see that the people at the higher levels have lower depressive symptoms. And this is converted omega-3 index from plasma omega-3 levels measured in 2,000 Japanese subjects. So people with the highest omega-3s levels in their blood, even in Japan, had the lowest relative risk of depressive symptoms. Omega-3 index, this compiles several different groupings of people across the health spectrum, mental health spectrum. We have that group of people with in the hospital for a heart attack, but also being checked for depressive symptoms, people with bipolar disorder, people with major depressive disorder, inpatient, people who are an inpatient for psychiatric needs, US norms, and then Japanese norms. And you can see on the omega-3 index scale, all of the groups who have who are sick in some way, mental or heart disease, are averaging much lower levels of the omega-3 index compared to the average US, and especially compared to the average Japanese person. So this pattern persists. And finally, let's talk about a specific kind of depression around pregnancy. This is a meta-analysis of 14 studies comparing omega-3 fatty acids levels in the blood. And these are, it didn't find an effect, a significant effect of omega-3s, of having higher omega-3 levels and lower risk of postnatal depression. That's this this diamond right here. It's crossing that main line just barely. It's trending in the right direction. But the prenatal depression literature did show a significant effect of having higher omega-3. So these are based on blood levels, which is great. And you can see there is a signal right there for depression around pregnancy. And then if we look at the postnatal depression, postpartum depression, this study did find a real interesting correlation. It was done in Norway, and they found when they took the omega-3 index at 28 weeks gestation, and then they compared that to a postpartum score from a questionnaire. And this is just a normal population of women not being supplemented in any way. There appeared to be somewhat of a threshold effect around 5% omega-3 index. The women who had a lower than a 5% omega-3 index had higher scores on the on the postpartum depression scale, and women on the effect kind of leveled out after 5%. There wasn't a huge difference between being at 5% or 8%. These women had lower risk. So it seems like, again, getting out of that very low, very deficient state is the most critical thing. And as you get higher and higher, there's still benefits, but those benefits, you get kind of a diminishing returns. So raising up the low end is really where we might see the best bang for our buck. I'm just going to go over one meta-analysis on anxiety. This is 19 studies. This was from 2018. We have about 2,000 people included in this. Found a significant association between omega-3 treatment and reduction in clinical anxiety symptoms. We don't have blood levels in here because they aren't measured enough in research. The big important note, this is going to come up later as well, subgroups with specific clinical diagnoses had better outcomes than those without clinical conditions. So people who have a actual specific clinical diagnosis, those were the studies that actually found the effects. People coming in with general anxiety or a less specific or less it's really important to do the diagnosis right at the beginning of the study, and making sure when you're treating someone and expecting to see some kind of effect, that there is a specific diagnosis that you're looking at. Those were definitely where the outcomes were found. The anxiety reducing effect in this case was only in studies with a higher dosage of over 2,000 milligrams or 2 grams a day of EPA and DHA. And in this study, higher EPA content was not shown to be more effective than the lower content. It really was just about overall dose of EPA and DHA. So again, a little bit conflicting information that we're getting here, but generally most omega-3s are good. So here's just the forest plot of the groups, the studies where there was less than 2,000 milligrams and more than 2,000. You can see that the overall effects of both of these are pretty similar, so they aren't seeing a huge difference. Psychosis, bipolar, suicide risk, and prisoner behavior. I'm clumping all of these together. The omega-3 index, just as we're looking at blood levels again and case controls, we see ultra high risk, people who are at ultra high risk for psychosis. And psychosis is a severe mental condition in which thoughts and emotions are so affected that contact is lost with external reality. So this is a really, really tough situation. Usually this turns into an inpatient situation. Looking at those people versus healthy controls and the red blood cell membranes, we see a decrease in the EPA and DHA and omega-3 index content by about 25%. So we see this pattern over and over again. This is a 2019 study that looked at the relationship between being on psychotropic drugs and the omega-3 index, I believe. Where is it? Omega-3 index. So the blue line is the overall drug usage. And then the anti-anxiety and antidepressant are the two major forms of those drugs. So it's kind of like the blue is the total, and then it gets a little more specific with the orange and the being the anti-anxiety and the gray being the anti-depressant drugs. Oops. So two things. The first is that if you look at baseline levels of omega-3s and whether or not people were on certain drugs, you see that a low omega-3 index was associated with an increased likelihood of that person being on a drug. And that's overall drugs, but primarily the anti-anxiety drugs. So we have that kind of cross-sectional relationship. But this was actually a trial. So they had 1,600 people over the age of 70 assigned to 4 different treatment groups. One was a multi-domain intervention with EPA or placebo. So they adjusted for age, sex, education, and geriatric depression scale. And so that baseline effect was before any of the treatment occurred. But after 1 year treatment, they found that an increase of omega-3 index was associated with a decrease in overall drug usage. So increasing the omega-3 index decreased the need for drugs in this population. And this was overall, but it was actually more prevalent and significant in the use of antidepressant drugs. So that's a really interesting study. Oh my goodness. Here's a study on bipolar disorder, and again, red blood cell measurements. Bipolar disorder is a mental health condition that causes extreme mood swings, and it's associated with low red blood cell DHA levels. So we have 6 studies of bipolar patients in their blood versus healthy control. And what we see here is that people with bipolar disorder have a lower DHA level on average, a significantly lower DHA. They have a trend for lower EPA levels in the red blood cells. Dr. McNamara is at the University of Cincinnati, and he's been really a major player in using omega-3s in psychiatric practice. And so here he is saying bipolar 1 disorder is associated with robust erythrocyte DHA deficits, and these findings add to a growing body of evidence implicating omega-3 deficiency in the pathophysiology of bipolar disorder. So it fits with the overall theme. They also, Dr. McNamara and Messamore, also put together these measurement or these graphs around looking at their inpatient in the psychiatric ward versus US norms. And this is really interesting. This is the percent of inpatients that have an omega-3 index of less than 4%. And for their population, 75% of their population is less than 4%. In the normal US population, which doesn't have great status, it's 25%. So you can see there's just a huge overrepresentation of low omega-3 status in this patient population. This is the same data over here, just split out a little more granularly. The black bars show the inpatient numbers and the gray bars show US norms. And you can see just so many more super, super deficient people who are inpatient. This is a study showing done in prisoners in Australia and New South Wales, and they measured the omega-3 index, and also they have 2 scales that they measure prisoner behavior on. One is the 7-point scale of aggressive behavior, and one is the Brown's Attention Deficit Disorder Scale. Anything that's in yellow is a significant relationship between the omega-3 index level and the outcome on this scale. You can see they are all negative correlations, which means a higher omega-3 index is related to a lower level on that scale. So a lower total aggression, lower physical and verbal aggression, lower anger, hostility. Anger, hostility, and total aggression are the main ones there. Activation, effort, affect, and memory were significant in the other scale. So those are all improved with higher omega-3 status on a cross-sectional basis. Final few studies on suicide. There's this study from China, a Chinese cohort, found that people with a low omega-3 index were more likely to be someone in the hospital who had attempted suicide. So it's another case control where they had 100 people who were suicide attempters and 100 that were in the hospital for an accident or other reasons. And they found that if they had higher omega-3 status, they were much more likely to be one of the controls. In lower omega-3 status, they're more likely to be a case, meaning it had attempted suicide. So there was an 81% lower odds of being a case in Q4 versus Q1. The risk for suicide in male US soldiers was highest in those with the lowest serum DHA levels. So we had serum here. 800 suicide victims. The military had blood on all of these soldiers' blood levels. So they were able to measure omega-3s in those blood levels after they had committed suicide. And then they were able to compare those to 800 controls, males in the US military. And they found if we convert to the omega-3 index, the highest group of omega-3 status was about 6% omega-3 index, and the lowest group was about 2.7%, if we can estimate. You can see it's not really a dose-dependent response. It's more of that threshold effect, where those who are in the highest group were much at a 50 to 80% greater reduced risk of suicide versus the lower levels. And that's, the first group down is already below 5%. So you can see just generally this pretty big, this group is very low in omega-3s and generally quite deficient. This looks at actual brain levels of DHA and finding that the people who victims of suicide who were depressed had lower DHA levels in the brain compared to controls. And this was again done by Dr. McNamara. The controls, some of them had cardiovascular disease. Those DHA brain levels were a little closer compared to the MDD, but the people without CVD had higher DHA levels. So that's kind of the research part, kind of wide ranging, lots of different kinds of studies. We still have a long way to go in having really good blood data in our larger clinical trials. Most of the blood work data is kind of population wide, and then they do supplementation trials, but fail to measure blood levels, which really, really affects the outcomes. But regardless, we still have some clinical recommendations. This is from Dr. McNamara, who has done a lot of publishing in this area as well as practicing. And he really does support measuring the omega-3 index, similar to measuring cholesterol. It's a valid, reliable, and relatively non-invasive measure of a patient's EPA and DHA biostatus. It allows, especially in this population, when we're starting to see over and over again, lower levels of EPA and DHA, very low levels in these patients, it's a really strong indicator that they need to be treated with high dose omega-3s. Another group, the International Society for Nutritional Psychiatry, has published some practice guidelines for using omega-3s in the treatment of major depressive disorder. So I'm going to go through what they recommend. Generally, number one, you should only start to use omega-3s as a treatment for MDD after applying the clinical interview to confirm the diagnosis, assessing mental status, and all relevant physical conditions, including checking on fish hypersensitivities. That may seem obvious, but it's really critically important to know what you're dealing with when you're trying to use this as a treatment, and so that you also know what to look for when you are following up in a couple weeks or a couple months. It found that omega-3s are better used as an adjunctive treatment than monotherapy. So it's better to use them as an add-on to current therapeutic medicines for adult MDD. They can be efficacious, they can be safe, they can be used in both an acceleration and augmentation setting. So an acceleration setting is when you start the medication and the omega-3 treatment at the same time. An augmentation would be they're on a medication, maybe it's not working that great, and they add an omega-3 to it. So in both cases, omega-3s can be used and can be safe. They like the research on EPA, so they say to use pure EPA or a high EPA to DHA ratio in a supplement, at least 2 to 1. It's pretty easy to find these days. And they are also, omega-3s can be used as adjunctive treatment for an acute depressive episode. It's less, the evidence is less clear around preventing recurrent major depressive episodes. So if it's an acute episode, they recommend using a therapeutic dose of 1 to 2 grams a day of total EPA from pure EPA, or 1 to 2 grams a day of EPA from a combined supplement. So they're really targeting getting at least 1 to 2 grams of EPA. So looking at your supplement and what you're using, you have to make sure you're calculating for the EPA content with these recommendations. So the total fish oil, total omega-3, total EPA DHA will be higher than 1 to 2 grams a day, unless you're using pure EPA. They recommend that dose for 2 weeks and then to check back in. And if the person is not responding by way of their symptoms receding, then they recommend a titration to the maximum dose in 4 to 6 weeks if it can be tolerated. Non-responders, if the symptoms are not changing on this dose, they recommend identifying whether or not the supplement is actually the right supplement to use. The other way you could really check on this is if you did take an omega-3 test at the beginning of this treatment, and then you took it again at 2 weeks or after 3 months, which is usually what we recommend. So they don't include testing in their recommendations because the testing is not as broadly available as it needs to be used in just any clinical setting. But the testing would be a critical piece to identifying if the non-response is due to a lack of absorption, a lack of taking the supplement, or the supplement not being the appropriate dose and type. So for recurrence and prevention, they said omega-3s could be recommended for a prophylactic treatment in high-risk populations along with standard medical care. It's not going to hurt. It's just as the evidence is not as clear. It's a lot harder to study prophylactic or prevention. You need a lot more people, a lot more money versus being able to treat an acute event. So I think that this is, they just don't have the evidence to really strongly say that they should have their patients on a certain dose of omega-3 long-term, but it certainly shouldn't hurt. And they say that you can elongate the acute omega-3 treatment to include maintenance and maybe prevent reoccurrence, but the evidence just, yeah. It's important to make sure that the safety effects of a high dose omega-3 are being watched for. So I'll include that list here in just a minute. They also recommend looking for maybe using a high quality prescription omega-3 product or a high quality product supplement on the market. Both can absolutely work. They are both omega-3s and high concentrations. Special populations, they're talking about people with major depressive disorder, but people who have that and are overweight or have high omega-3 or high inflammatory markers would definitely may have extra benefits from the omega-3 treatment. Also, women with perinatal MDD, elderly children, and adolescents. It's really across the lifespan. Omega-3s are a nutrient and they're shown to be beneficial for a lot of reasons. So they're safe. They can be used for a lot of different populations. And just to quickly say what the pharmaceutical omega-3 options are, if you wanted to go that route instead of finding a high dose supplement. The two primary ones that are available are Lovesa and Vasipa. They're both ethyl ester forms, so there is a potential issue with absorption that would need to be, that's where testing would help you find that out. Lovesa is EPA and DHA. It can, if you take one capsule, you get about 840 milligrams a day. EPA and DHA pretty evenly distributed between the two. Vasipa is also kind of 1 gram per capsule type of prescription. It's just EPA. So that one you could really just get away with 1 or maybe just 2 capsules with that. But again, plenty of options on the market for a good high quality supplement, but you really need to make sure you're looking at the supplement facts panel, calculating how much EPA there is. And I would recommend the total EPA and DHA per serving per capsule to make sure you're getting to those therapeutic doses. For safety, the potential adverse effects to be looking for are burping and nausea, issues with potential skin issues, higher LDL, glucose, and potentially lower hemoglobin hematocrit. Other possible issues with antiplatelet or coagulant agents. Those are just something to be aware of, but we have not seen any indication that omega-3s increase bleeding risk above and beyond what they already are if people are on antiplatelets. So these are just generally things for clinicians to look out for if someone's on high dose omega-3, but a generally quite safe treatment. So to wrap it up, omega-3 index is lower in individuals with mood or mental disorders on average, compared to healthy controls. Supplementation has been shown to improve symptoms of major depressive disorder and anxiety and other mental disorders, but specifics around dose and EPA versus DHA are still somewhat unclear. Ensuring that the diagnosis of depression and anxiety is clinically assessed and documented is critical to determining if the treatment was effective. Omega-3s have not been shown to significantly benefit general mood. So if someone is not clinically diagnosed with depression or anxiety, the omega-3s won't hurt, but they aren't shown to be, there's not a lot of evidence. The evidence in the literature does not support that they will significantly help that group of people. It's kind of people who already have a more severe disorder that you will see those effects in a short period of time. So I don't think it's a bad idea if someone does say that they're having little issues with mood. It's very vague. It's not clinical. The omega-3s aren't going to hurt them, but also setting expectations around this is key. It's not a guarantee. There are lots of variables around these disorders, of course. So if omega-3s can help with very little risk, then I would absolutely consider it something that's good to use. Just don't promise the moon. There's a lot more complicated stuff going on here. So we would recommend, if you have access, testing the omega-3 index levels at that first visit, prescribing the appropriate amount of EPA and DHA, but making sure you're getting enough EPA to get to 8%. Usually 1 to 2 grams is good. Some people need 3, 4, trying to get that blood level up. And what's recommended just for supplementation is also kind of matches what it takes to get to 8%. You also could recommend a fish-rich diet if someone wanted to go that way. And then retesting in about 4 to 6 weeks, a little shorter time frame potentially if it's kind of an acute depressive event, and just giving it a little bit of time. We usually recommend at least 12 weeks of supplementation. But in this population, you might need to retest earlier, especially if you are assessing mental status and it's happening at a quicker turnaround time. With these doses, you should start to see improvements in the mental status, but the blood levels will start to go up, but they will not be at steady state until at least 4 to 6 months. So the 4 to 6 week check would allow you to see if they're absorbing it. Are they getting some kind of bump? If they were starting at 3%, they might be at 5 or 6% after 4 to 6 weeks, and you would expect that to continue to go up over the next 12 or the next weeks. So that is the final slide. So like we said, nutrition talks, the next one is September 19th, and we will cover omega-3 and concussion, as well as traumatic brain injury and all those really interesting areas of research. So thank you, and I'll take some questions.
Excellent. So we've had some questions. If y'all have questions for Dr. Harris-Jackson, please put them in the Q&A section. I saw a few come through the chat, but please direct them to the Q&A. As we get started on questions, the first question is there an EPA level that we're aiming to achieve, or just using EPA to get the omega-3 index to an ideal range?
At this point, we're using the omega-3 index to get to an ideal range. Unfortunately, EPA has an interesting effect on the omega-3 index. Pure EPA is not as effective at raising the omega-3 index as EPA and DHA together, even at the same grams per day. It actually lowers DHA levels in the membrane. There seems to be, it's interesting. So what's going on with EPA is not entirely clear, but getting a supplement, I would rather be taking a supplement that does have both EPA and DHA, and I would try to be getting to 8%. And that's kind of where, when we try and get too specific with some of these, like exactly how much EPA and exactly how much of this, the evidence is just not there. But we do see kind of, if you take a step back, getting to a high omega-3 index and having EPA in your diet, those are two kind of the broad strokes that you should be looking at.
Is there any advantage to be at the top end of the index, let's say 12% versus the middle 9.5? If yes, would you suggest supplementation if regular diet includes a good amount of omega-3 fish?
In the Japan studies, we see there actually is continued improvement. Even once you hit 8%, getting to 10 and 12, we see lower risk in the heart disease world. We also see one of the studies here for depressive symptoms. But you know, there is some level of diminishing returns. Like at the same time, we see for the most part, the worst of the symptoms are happening in people who are very deficient. But if you want to get up to those levels, what it takes for you, and if it's worth it, if you're feeling a difference between being at 8 and 12%, then that's worth it for you. I think this is a very individual thing. Once you start to be at those high levels and maintaining those, you do want to make sure you're looking at some of those potential safety issues, just keeping an eye on those things, making sure you're not getting out of whack, because getting this all from fish versus a supplement, we still don't understand what it means to take that high of a dose of a supplement for decades. The studies usually only go 5 years or so for those like 4-gram doses. So I think you're just kind of getting out of a nutritional dose once you're over 2 grams a day. And I would just keep an eye on your other health things, make sure that everything still looks good there.
Why do athletes have lower levels of omega-3 index?
It's a great question. A lot of them don't eat a lot. We also see the younger people tend to have lower levels we're not really sure why. It could just have to do with diet. And athletes, we think, are using up they're potentially burning their omega-3s more so than anyone else. And the body preserves omega-3s. It does not want to burn them, but it will if it has to. They also seem to have a higher turnover in red blood cells. So the red blood cells are fresh, which is good, but that might also affect the omega-3 content and availability. So it's kind of, and the other thing is, over the course of a season, we've seen that omega-3 levels decrease. So there is something going on with they are experiencing higher levels of inflammation, concussion potentially. The body's using the omega-3s, we think, in those kind of high inflammatory events that they're encountering every day in practice. They're challenging their bodies. So the omega-3s, I think, are being depleted in that way too.
In the meta-analysis of studies on omega-3 and depression, did they look at overall omega-3 or specifically DHA, EPA?
I think it was these are specifically EPA, DHA. There's one other study I found, a meta, that saw something for ALA, but it was over like 40 months of supplementation, and it was like one study. So we're focused on EPA and DHA here. It doesn't include ALA.
This is a good question. Is there an age in which supplementation to increase omega-3 doesn't help to reduce negative mood? For example, let's say if you're over 80.
Great question. I don't know the answer to that, but the studies from the first meta-analysis that I showed, that was in people older than 70 years old. So I think it still is effective. Even they call it like geriatric depression. It's still effective for people of that age, I would say.
Do you know if there's any research on genetic variation? For example, if the individuals have gene X, they actually should be aiming for a higher or lower omega-3 index.
Oh, well, that's a good question. There's a lot of like omega-3 genetic research that's mostly related to the enzymes that convert ALA to EPA and DHA in the body. Some people are better at converting that than others. But as far as if you would need you need to have a higher omega-3. The main thing genetically that we've seen that it's really, really beneficial for these people to have the high omega-3 and maintain it is ApoE4 people. That's starting to become very clear that if you have that genetic marker, you are it would be very good to have a high omega-3 level, extra beneficial.
So a few questions. I'm going to switch to the chat because a few just came in. There's another one I'll get back to in the Q&A. Any cardiovascular risk with higher AFib or with AFib with higher omega-3? And I think there was a big new paper just came out on this.
Yeah. AFib, yes. Good question. So we have published AFib. There's like two stories. This is kind of common, but the main story that first was coming out was from these pharmaceutical studies giving 4 grams a day of EPA and DHA over 5 years to people who already had secondary CVD. So they were already taking statins, metformin, and blood pressure lowering drugs. Adding 4 grams a day onto that milieu caused about a slight increase in AFib risk in the omega-3 arm. I think it's like a 10% increased risk. There wasn't an increase in stroke risk, and there also wasn't an increase in risk for heart disease or dying from a heart attack in those groups, but there was a slightly elevated AFib risk. And then what we see when we look at the biomarker data, the cohort data, the dietary data, over time, if you have a higher omega-3 intake or higher omega-3 blood levels, you're less likely to have AFib. And that's just a completely different process. You're talking about a prevention process there. So having high omega-3 levels and not having that first heart attack and not having to be on those medications, those folks are not at higher risk for AFib. We also have, so the FARI group, the Fatty Acid Research Institute, I think they just published on this, on kind of the cohort work. And then they also worked on looking at if stroke was increased in those supplemental studies, and not having an increase in stroke is really the main fear of AFib, is having a stroke. So yes, there is something there on the AFib front, but in the broader picture of things, omega-3s as a preventative, still really important. And if you have someone at high risk for AFib, important to know that, and maybe you don't put them on as high of a dose, or maybe you just suggest going to try to go the fish route, but still trying to get some omega-3s in kind of a safe way for those people.
Which lab testing method for omega-3 is most useful, and which lab method is least likely to be accurate for physiological omega-3 levels?
Yeah. So we are at OmegaQuant, we are a lab, and we are based, we exist basically to run the omega-3 index test on red blood cell levels. We think that is the best metric of status. We think the other way you can measure status, you can measure it in kind of anything you want. You can measure it in plasma, you can measure it in plasma phospholipids or in cholesterol esters, measure free fatty acids. They all mean something else, and they all are generally correlated with each other. The problem is with the plasma levels specifically, they're much more variable. Every time you eat fish, 4 hours later, you're going to have a bump in your plasma or take a supplement. If you, for the red blood cell, it's more like HbA1c. So it's 3 or 4 months of intake kind of compiled into that membrane. It represents tissue status. It doesn't get perturbed if you take a fish oil supplement and then take a test right away or at 4 hours. It doesn't affect the red blood cell level because that's a longer term marker. They both have their purposes. So there are studies where you definitely want to use a plasma marker to make sure the absorption is happening. That's how we can see that. But for general status, for clinical use, we would say definitely the red blood cell omega-3 index. It's also the one with the most research behind it that shows that these targets of 8% or 4% being a very kind of a deficient status, we have so much data behind those numbers, and the plasma levels do not have the same backing up data, I'd say.
Do you recommend testing AA to EPA ratio instead of just the omega-3 ratio to get a better indicator if EPA is low?
You could do that. So you can get both, and the omega-3 index is a combined score of EPA and DHA, so it is hard to see. You can't tell from just that. Typically, the omega-3 index and a red blood cell is about 85% DHA, 15% EPA, and kind of a natural membrane. We've seen more and more closer to a 50-50 split on that as people are taking those really high dose pure EPA products. The AA EPA ratio could be useful if you just want to take a look at the EPA level, because EPA is driving that ratio. The arachidonic level will respond to EPA. So the more EPA you get in, the lower arachidonic will go. That ratio can shift wildly, and because the numbers are really small. So having both the omega-3 index and that ratio, you could be able to have a pretty good idea that the omega-3 index, you still want to make sure that's getting close to 8. And if the EPA and DHA, EPA AA ratio is in if the omega-3 index is close to 8, that ratio is going to be in the good range. But it also will just kind of be a secondary confirmation that you are getting a good amount of EPA.
And I think there was one more question in the chat. How much should a normal healthy person take? I take Eskimo fish oil, 230 EPA and 180 DHA. Why is taking too much not good if you're healthy?
Yeah, it's a spectrum. Taking 500 milligrams a day for your whole life is better than taking 4 grams a day for 6 months of your life. It's better to take it consistently over time, build it up. This is part of where we look at these long-term studies where kind of a more nutritional dose, which would be like less than a gram a day over a lifespan, has really good evidence that can prevent, can be really good for a lot of health outcomes. However, we also see that amount it'll get you out of the deficiency range. It won't get you towards the 8%. And we do see a continual improvement or reduction in risk as you get to the 6% and then 8% and then 10%. So while not being deficient is great and really reduces risk for a lot of things, we also see improvement, continuing lowering of risk as you get higher. So it's kind of a personal decision on how much of that risk are you going to try to reduce with what you're taking. If you feel like I can't take, let's say I don't feel like I can take 2 grams a day for my life, but I think I can take 500. That's a great place to start. add some fish in, make it a part of a continual habit. That would be my preference, versus just feeling like you have to be at the highest levels. It's at taking the highest dose. That some people need that to really see this effect. Some people don't. Most people probably just need that more nutritional dose over a long period of time, along with a healthy lifestyle.
Any other questions? If you have any additional questions, please put them in the Q&A, or you can put them in the chat. I'm kind of monitoring both. If you do not, as we mentioned, as Christina mentioned on the last slide, Tuesday, September 19th, 12 o'clock Central Time, our last brain series topic will be omega-3 and concussion TBI. So be sure to mark your calendars. You will get a notification soon. Once that registration page has been created and available, you will have a chance to do that. I will also be sending out, once available, a copy of the recording of this presentation. So it will be a video recording. We are not able to share the slides. If you are a dietitian, you will also get a copy of that CEU. And by that time, I should have the link to register for the next webinar. Also, before the end of the month, we should be launching OmegaQuant University. We will be launching OmegaQuant University. So a lot of our previous webinars will eventually be loading into that, and we'll be starting with adding our first webinar, and that will be Omega-3, the technical details of testing. As always, we appreciate those of you that attend and register for our webinars. We look forward to seeing you in the future. If you have any additional questions, especially if you have questions, reach out to Christina or myself. You can also email me if you have questions about setting up a practitioner account and wanting to offer testing inside your practice. All righty. Any other questions? You can add them now. If not, we will see you at the next webinar on Tuesday, September the 19th.
Great. Thanks, Thomas. Thanks, everyone.
Thank you all. Have a great day.